Gynecological cancers are complex. While ovarian cancer incidence has not changed, uterine cancer is actually increasing while cervical cancer is decreasing. An expert in this field of gynecologic oncology will discuss the latest findings and treatments in this field on this week's Health Talk. So stay tuned, we're up next. Hello, I'm Dr. Eric Mazer. Today we're going to talk about gynecologic oncology with Dr. Vaagn Andikyan, who is with Western Connecticut Health Network, i.e. Norwalk Hospital and Danbury Hospital, and you're a gynecologic oncologist. So tell us a little bit, how did you get interested in the cancers of women?
I always prone to choose challenging cases, and in my residency training I was naturally drawn to surgical approach and complexity of the problem and the involvement multiple specialists, and be able to provide up-to-date care with focus on quality of life, surgery, and bring back those patients back to their community. Therefore I choose this specialty.
Now gynecologic, particularly ovarian cancer, is almost unique of solid tumors. As some of our viewers know, I'm an oncologist, and I was around during a lot of the clinical trials when we discovered that unlike many solid tumors, if you could just reduce the bulk of ovarian cancer below a certain level, you could really improve the outcomes. Could you say a little, but that could be very complicated too, so
absolutely.
Tell us a little bit about that.
Yeah, absolutely. Yeah, it's one of the few cancer where the debulking surgery has a critical role in outcomes of patients. By removing as much as tumor possible safely, you provide the best possible outcome for those patients. Several studies in 70s showed that patients who were able to debulk, otherwise resect all visible tumor to less than 1 centimeter, those patients did the best.
Which is
in
really
terms
sort
of
of
survival.
amazing, because the standard with most other solid tumors, so lung or colon, is if you leave disease behind, if you can't get it out surgically, you pretty much have no chance of curing the patient. And yet here we have a disease where if you leave fragments of tumor behind, you said 1 centimeter, that's about 1/2 inch, you could still treat and sometimes cure those patients with adjunctive radiation or chemotherapy, right?
Yeah, yeah, absolutely. Radiation has been used in the past. Nowadays we use chemotherapy. We're lucky enough that ovarian cancer is very sensitive to chemotherapy. Two major drugs on the market are carboplatin and paclitaxel. Those are the very strong drugs, and ovarian cancer typically sensitive to those drugs. Therefore, by removing as much as tumor possible, ideally you want to take out all visible disease, if it's feasible.
Yeah, and why don't you explain that to our viewers, because I think most people think you go in there, why can't you take it all out? Explain to them why there's sometimes you're forced to leave small deposits of disease behind.
Absolutely. So ovarian cancer originates from ovaries, but it's spread out inside the abdominal cavity. So what abdominal cavity is? It's a bowel, intestine otherwise. Omentum, it's a fat pad that hangs over the stomach. The ovarian cancer may go into the liver, spleen, diaphragm, it may go into the lungs, it may involve the roots of the bowel. So essentially, to take out the entire cancer, you got to take out all intestine, and those patients are not able to live. Right. So therefore, we depends on the volume of disease. Sometimes we give chemotherapy up front to melt the disease and bring the patient for interval debulking, interval surgery. Or if it's feasible, we take it in one shot.
Now, talking still about ovarian cancer, I think, again, it has an unusual pattern of spread compared to most tumors. Most tumors we think of metastasizing or spreading by the bloodstream. Sarcomas are typical, and they will typically spread to the lungs, or some tumors will spread to bone. Some tumors spread by lymphatic drainage. But ovarian cancer seems to spread along the surfaces of the peritoneum.
That's correct.
Maybe you could say a little bit about that, because it's a really unusual pattern of spread, and it does lead to this complicated situation where a tumor down here can have deposits throughout the abdomen affecting vital organs.
Absolutely. So the ovaries itself located in the pelvis. It's a pelvis, it's our lower part of our abdominal cavity. So there is no border between pelvis and abdomen. So therefore, these cancer cells, by natural spread of the fluid, they travel from ovary into the abdominal cavity.
It's almost like they see the cavity,
Absolutely.
just like if you were to scatter grass seed out in the backyard.
And naturally, our abdominal cavity contains small amount of fluid. Cancer cells sheds inside that fluid, and the natural flow of the fluid along the gutters, along your colon, they travel from up to the diaphragm, to the liver, to the spleen, and go down into the pelvis. Therefore, we have a small disease in the ovary, but it's spread out everywhere.
And this is really why this specialty of gynecologic oncology has become so important, because the quality of the surgery that's done in these states called stage 3 disease, a disease which is spread in the abdominal cavity, the quality of that surgery is really the crucial first step to getting a good result down the road, isn't it?
Absolutely, it's critical. It's critical to make sure this is a primary tumor from the ovaries. About 10% of the time you have metastasis from other sites, from your colon, from other part of your body. Therefore, before we proceed with the surgery, we perform complicated and intense workup that may include CAT scans, colonoscopy, taking a history, physical exam, and we're sure that it's an ovarian cancer, we'll go after it. The whole idea of the surgery is to make it safe for patients, to preserve the quality of life, meanwhile resecting all visible tumor possible.
Tell me, what are some of the most difficult areas to resect? Again, for people at home who aren't used to this idea, and what makes it difficult? What position or where do you not like to see disease because you know it's going to be tough to get it out?
So usually if you see the disease underneath of liver, it's tough spot. Because
so this is up behind the liver?
Yeah, right here where the gallbladder is. We call that area porta hepatis. It's where the major vessel goes into the liver. That's a very tough spot because the injury can occur to the major vessel, and that could be catastrophic. Then you don't want to see the disease on a small bowel mesentery. Mesentery is a vessel that fits to the bowel. So those are the tough spots, and if you see widespread cancer of there, so it doesn't mean we cannot cure this patient. It means that surgery upfront is maybe not reasonable. So for those patients who we discover unresectable, we give them chemotherapy first, and we shrink the disease to the volume that is safely resectable, and we bring them in a couple of months for interval surgery.
And that's really interesting, and people may not realize that this is done, but the chemotherapy can be sufficiently active and beneficial that it will shrink the tumor and create take a non-surgical patient or a high-risk surgical patient and make them doable.
Yep. This study came from Europe that showed that those are the two reasonable approach, chemotherapy up front versus debulking surgery. So, and you select your patient. The most important to decrease complication after surgery, meanwhile providing best survival outcome. That's a balance every surgeon bears in mind when makes a decision.
And this is something called neoadjuvant therapy.
Correct.
Which is, now the other thing is, since the disease typically implants on the lining of the peritoneum, and again, for our folks at home, there's actually a virtual space in our abdomen which covers our bowel and covers our anterior wall, which usually has just a tiny bit of fluid in it. But it actually can be expanded by fluid or air or things like that. But the cells tend to spread along this space. How about the use of chemotherapy right into the peritoneum? I know this has been used in certain circumstances. What are the circumstances where this is now considered beneficial?
Yeah, that's several studies were done in America that showed actually those patients who are debulkable, meaning that we removed all visible cancer cells and there is no gross tumor left behind. We placed special catheters inside the abdominal cavity, and through these catheters we may deliver high-dose chemotherapy directly into the organ. For us, organ for ovarian cancer, it's abdominal cavity. We deliver high-dose chemotherapy inside the patient's abdomen, belly, and we also support them with systemic chemotherapy that goes intravenously.
Yeah, interestingly, and again, for our viewers at home, the chemotherapy in the peritoneum, in the abdominal cavity, can be quite high dose because it's not getting to all the organs, but it only gets a few cells down, doesn't it?
Right.
How deep does it
It goes
get?
up to 3-4 millimeters. That's good enough because ovarian cancer rarely goes deeper. And that's why when we have large volume of disease, if it's not resectable, we don't give intraperitoneal chemotherapy. We know that chemotherapy won't go through the all layers.
Now, let's go back a little bit. One of the problems with ovarian cancer is that we don't have good screening tests, and that even the symptoms can be late and nonspecific. So tell us a little bit about who's at risk and who should seek help, and how worried should people be about ovarian cancer?
As you mentioned, unfortunately, we don't have specific symptoms that will raise the alarm and the patient will see us. So first of all, pay attention to your body. If you feel like you're losing weight, your belly getting bigger, or you bloated, or you have changing in your bowel habits. So this is alarming signs. So unfortunately,
these are pretty
unspecific,
common things and
unspecific,
nonspecific.
absolutely. But be concerned about them. So, and another factor, if you have a family history of cancer, bring that attention to your primary care physician. Hey, my mom died of ovarian cancer at the age of 55, or my grandmom had breast cancer, and my sister had ovarian cancer. Those are the genetic mutation that increases the risk of ovarian cancer.
You've made an important point, so I want to emphasize that. It's not just a history of ovarian cancer. Breast cancer can migrate genetically with ovarian cancer. Are there others, colon cancer, thyroid disease, or do those migrate with ovarian?
Yeah, Lynch syndrome. So there's a syndrome, there's association between colon cancer, uterine, and ovarian cancer. So that's why important to, if you have a history in your family, bring attention to your doctor. Ask them questions. And if they don't know the answer, come to see us. We'll be happy to do certain tests to evaluate that. We have a genetic counseling team. We have other specialists on board with us who could provide comprehensive and complex care locally.
And I guess we should emphasize, too, that the younger the age that a relative has one of these cancers, the higher the alert should be in your mind.
Absolutely.
Because the genetic cancers tend to occur at younger ages. So an 85-year-old grandmother with breast cancer doesn't have the same risk as your sister who had breast cancer at 35.
Absolutely, you're right. So the younger age, multiple family members, those raise alarm for us that something, genetic information needs to be checked.
And maybe we could talk, we have to take a break right now, but when we come back, let's talk a little bit about some of the risk factors for ovarian cancer other than family history. So,
happy to.
So we're going to take a break right now. We'll be back after this short break and talk a little bit more about ovarian and other gynecologic cancers. Hi, we're back with Dr. Vaagn Andikyan. We're talking about ovarian cancer. We've covered, I think, the importance of family history. And if you have a family history, you should really be talking to somebody. And again, it could be ovarian, colon, breast cancer, and particularly a younger first-degree relative. But let's talk about other things. What can people do to either prevent ovarian cancer or reduce risk factors for ovarian cancer? We do know some things about that, don't we?
We do. So as we know, about 10 to 20% of ovarian cancer are related to genetic mutations. So by finding those 10 to 20% patient in general community, we will be able to take out tubes and ovaries and decrease the risk of developing ovarian cancer in the future.
Now, can we allow enough time for that patient to have a family before we remove their tubes and ovaries?
Absolutely.
So they can have a family and then go on and have the preventive surgery?
Oh, absolutely. Usually the risk of ovarian cancer picks up after the age of 40, 45, 50. So that gives enough time for women to complete the childbearing.
Now, could you go over some of the genetic mutations? Because I think they're beginning to get familiar in the lay population. We know the breast cancer genes, BRCA1 or BRCA1 and 2, are related. I've forgotten which one is stronger. Could you go over that for us?
Absolutely. BRCA1 and BRCA2, those are the genes that are involved, not just the breast cancer. Vast majority of those patients will develop ovarian cancer in the future. 80% of the patient will develop breast cancer, about 20 to 40 ovarian cancer with those mutations.
With both mutations?
With both
Or
mutations.
with either mutation?
With either mutation, BRCA1 or 2. BRCA2 mutation tend to develop ovarian cancer later on in their life, in late 50s, versus the BRCA1 mutation earlier onset. So that's why we individualize our approach to certain patients. But in general, if we discover those mutations in these families, we'll counsel the patient extensively that this is probably needs to be addressed. And
it's a simple test, isn't it? Do they do it by the buccal swab, or do they do it by blood?
Yeah.
Buccal swab. So it means they just literally rubbing a Q-tip around your mouth. So it's nothing painful. They don't have to biopsy the ovaries. This is a simple test.
It's not, but the consequences is very important. You got to realize this is a genetic information. You need to know this information that may affect not just you, your ancestor, your family. So some people feel anxiety about that too.
Oh, and it's very important. I've learned my lesson in a couple situations. I had a patient who was actually a malpractice lawyer, and she had had early onset breast cancer, was worried about her other breast. Right after the BRCA mutations came out, she came to me as an extraordinarily well-informed young woman and said, I want the BRCA1, BRCA2 test. And I thought, well, she's well-informed, she's read an extraordinary amount, she's actually focused on malpractice. And I said, sure, and we got the test, and it turned out positive. And she was not ready for the reason, and emotionally, she was not ready for that. And
absolutely, because it's changing your life.
So people need to do this in the context of genetic counseling. I think for a while some of those mail-away tests were giving you those results too, and they're just devastating. You need to do this with somebody who can help you plan out the contingencies, so it's not a minor undertaking.
You're not alone with this result, and you're frazzled. You don't know what to do, how it's going to affect your life, how it's going to affect your life, your children. So that's why when we offer this test, before we ordering tests, the person sees a genetic counselor. We get a detailed history. Who needs to be checked? What type of mutation needs to be seen?
So in addition to the BRCA1 or BRCA1 and 2, the Lynch syndrome, are there others that we look for?
There are so many of them. It's hundreds of genes in a panel. Most important is BRCA1 and BRCA2. There's another mutation, CHEK2 inhibitors, BRIT. So in general, I like to sit down with the patient, send to appropriate genetic counselor that we can go over what potential testing needs to be done. So instead of ordering widely and without knowing what we're going to do with these results.
Now you said that if someone does have the high-risk mutation, say one of the BRCA genes, you remove the ovaries and the tubes to reduce the risk. How about screening? We've talked about screening for ovarian cancer for years, but it never seems to live up to the hope and expectations. Maybe you could say a few words about it.
Yeah, you're right. Unfortunately, the existing technology that we use broadly to detect benign diseases of gynecologic origin, they're not very helpful for screening tests. There is no good data showing that those tests help patients live longer. So in other words, we'll do a sonogram or some blood tests. By obtaining those results, we're not helping patients live longer. That's a major critique for those screening tests.
Now, some people are still doing that if patients don't want to remove.
Absolutely, yeah.
But I think the point is
that we don't have screening tests, but if you carry those mutations and you don't want to have surgery done because of logistics, because of your age, etc., we offer sometimes sonogram or CA-125 with clear understanding this is not a screening test.
Now, the surgery for the BRCA gene is quite extensive, because you're talking about probably, if you're going to prophylax a patient, you're talking about bilateral mastectomies as well as taking out the ovaries and tubes. That's awfully hard on people, isn't it? How do they deal with that emotionally?
It is hard. Right now I'm treating a patient who is diagnosed with breast cancer. She is receiving chemotherapy, and she will have her mastectomy done in February. So she saw me, she knows that she carries the risk of this mutation, and we're planning after she finishes her treatment for breast cancer, we'll address her ovarian cancer risks. So she doesn't have ovarian cancer, but she carries these risks. So what we are doing now, minimally invasive surgery. So risk-reducing salpingo-oophorectomy, removal of tubes of ovaries, it's a same-day procedure.
Oh, really?
We'll do a small incision on abdominal cavity. We take out those tubes and ovaries safely, and the patient goes home. Actually, in terms of ovarian cancer risk-reducing, it's very, very minimal risks. For breast, yes, it's a major surgery. It's a reconstruction. It's a removal of breast tissue. It's more complicated. But for ovarian, luckily, surgery could be less traumatic.
Now, while we know for breast that bilateral mastectomy doesn't absolutely prevent breast cancer, it reduces it considerably. Is that also true for ovarian cancer? Can someone still get ovarian cancer without having ovaries?
Not ovarian, primary peritoneal. They may develop, there is a residual 5% risk after when we do removal of tubes and ovaries, develop cancer inside the abdominal cavity.
It looks like ovarian cancer.
It looks like ovarian, it's treated like ovarian, it has same mutations, but that's a cancer cell that arise from peritoneal, lining of your abdomen.
So given all comers today, unfortunately I know that we still are not detecting people in the earliest of stages most of the time. How good are we doing in terms of cure?
Cure for stage 3 and 4 disease is a ballpark 50 to 60%. It depends of volume of the disease, whether this cancer was resectable completely, and B, whether this cancer responds to chemotherapy.
So is that another reason perhaps to treat ahead of time to reduce the bulk, so you can also see if it's responsive to chemotherapy?
True. So yes, if you give chemotherapy up front and the patient is not responding, progressing, that's probably not the best scenario. It means that this cancer is very aggressive, and by doing surgery up front may not benefit because the cancer may grow back pretty quickly.
Are there other things people can do to reduce their risk of ovarian cancer? I know for a while there was discussion about exposure to talc during infancy. I know also exposure to birth control pills early on in a woman's reproductive life may affect risk. Can you say a few words about that?
Yeah, absolutely. So patients who were using birth control, it seemed like decreasing risk of ovarian cancer. And the exposure to talc increases the risk of ovarian cancer. What happens when you're using birth control, the patient don't have ovulation and the surface ovary is intact. When ovulation occurs, the abnormal cell may build up there. By reducing this ovulation process, you're decreasing the risk of ovarian cancer. However, it's always a pros and cons. It may decrease ovarian, but it may increase your breast and
increases your risk of
other
clotting.
things, clotting, etc. It's always a balance. So always, there's no magical pill. We have to take into consideration patient history, risk factors, what she's interested to make these complex decisions.
If you have a patient with a moderately strong history of ovarian cancer but no genetic mutation that's identifiable, will you ever recommend a course of birth control pills as a prophylactic kind of maneuver if they're young, or is that not used therapeutically?
It's not used therapeutically. For younger patients, we tend to observe because incidence of ovarian cancer at younger age is very low. We're talking about epithelial cancer. We should also understand that ovarian cancer, there are 4 or 5 diseases in one ovary. They're not the same. So some cancers of ovary arise in younger age. They have different physiology.
That's a very important point, and we haven't made it, is that these are really, we're talking about largely the run-of-the-mill ovarian, but there are various kinds.
There's maybe 20, 50 type of ovarian cancer. So that's why important to see the specialist, that we can have an in-depth conversation and discuss what the symptoms, what the findings are. And even patient have ovarian cancer at younger age, sometimes we preserve fertility. It doesn't mean that we have to take out both tubes and ovaries. It's reasonable for stage 1 disease, save other ovary, that the patient may have children in the future.
Is it good for a woman to have a bimanual exam yearly or every other year? Has that been shown to be beneficial in picking up ovarian cysts or ovarian
It's very
cancers?
important. It's very important. Still, if you don't see, it's very important to see your GYN doctor or your primary care physician at least once a year and to perform a vaginal exam. So that by manual exam, we may be able to pick up some cyst. I've seen a patient who was her OBGYN physician picked it up during annual exam and referred to me, and we diagnosed with early stage ovarian cancer, and we were able to save this woman.
And that does happen, even though it's not been demonstrated as a screening test. It's clearly something that's simple to do, it's inexpensive to do, and it's one more way to potentially protect yourself. This has been so informative. Unfortunately, we didn't get a chance to talk about endometrial cancer or uterine cancer or cervical cancer, so we'll have to have you come back because those are very different cancers. And I think one of the exciting things, and I think we'll talk about that as we answer the question, is we actually have a vaccine now that can prevent cervical cancer. It's sort of miraculous that we can give vaccines that prevent cancer, and we'll want to talk about that when we come back.
Perfect. We'll be happy to, Eric.
Okay. So I want to thank Vaagn. I'm going to got your name right, Vaagn. And when we come back, we'll have today's health question. Hi, this week's health question is, what is HPV? HPV has really revolutionized our understanding of cervical cancer. It's a virus. Tell us about what it is, what impact it has on the cervix, and especially about the vaccine.
Yeah, we knew about this virus 56 years ago, and that's a DNA virus that incorporates into the cervical cells and change the biology.
It's something called human papillomavirus. That's where the HPV comes. And it spreads sexually, isn't it?
It's transmitted sexually, and there is no good protection in terms of condoms. Does not necessarily protect against this virus. However, we have something to offer to our patients. It's a vaccine. So vaccine is active against certain type of papillomavirus, HPV. Not every type is covered, but the 4 major types that may cause cancer or benign warts, they covered, the vaccine covers those types.
And who should be getting the vaccine?
So ideally, it's before exposure to this virus. The younger, the better. So it, typically between the age of 9 and 15. And could be given up to age of 26. And
this is given to women who, before they become sexually active? How about men?
So that's a very interesting point. So it should consider for men as well, but that's ongoing process.
So right now it's recommended just for women, but men should think about it and be aware of this.
Absolutely.
And once you have the virus, the vaccine doesn't help you wipe it out.
It does help, but it won't give you 100% protective effect.
And if you are protected by the vaccine, does that eliminate your risk of cervical cancer?
Not necessarily. It decreases risk by 90% because there will be still other viruses that are not covered by this vaccine.
That's a pretty good percentage. 90% get a vaccine and you don't get cervical cancer. Well,
and we'll see that because incidence is going down.
Just fabulous. That's modern medicine is doing. Okay. So if you have a question you'd like to ask on Health Talk, please contact me at healthtalk@norwalkhealth.org. I want to thank our guest today, Dr. Vaagn Andikyan, for coming on the show, providing us so much information. And I'll see you next week on Health Talk. Bye-bye.